Hi guys, welcome back to my channel, Dr. V. I'm an OBGYN IMG, currently preparing for RCPSC exams. So from the last few days, we're studying the topics advanced ultrasound. So I'm gonna go through some of the important topics which are related to the exams, related to the ultrasound. So let's revise. So ovarian torsion, most commonly asked question, and also it's a very important topic we see day to day. So what do we see in ovarian torsion? So ovaries get enlarged and there is peripheral follicular displacement, so it looks like a PCOS kind of a picture on ultrasound because the blood flow is not very characteristic, because the first thing to go is the lymphatic and the venous obstruction, and the arterial flow still remains, so it doesn't exclude torsion, and Doppler sensitivity is also low. What is a post-surgical cervix? So post-surgical cervix means either having any cold knife conization or any LEEP procedures. It is important for future management for pregnancy. So the cold knife conization has a higher risk since there is a larger excision of the cervical stroma. So how we can do an ultrasound assessment? So the transvaginal ultrasound is more important because it has to visualize the entire endocervical canal. So what is the two-segment rule in case of a curved cervix? So if the cervix is curved, we don't take straight line measurement from the internal os to the external os. So we will take all the curved lengths and then we'll add it up into a straight line. So two segment measurements. And most important for the cervical length screening is it is a dynamic assessment, and it has to be done for at least 3 minutes, which we do every day. So if there is conization alone, it's not an indication of cerclage. So if she has any history of preterm births in the past, then cerclage could be an option. But if not, then monitoring the cervical length through serial TVS is important. Okay, so another important thing for the fetal growth restriction in the Dopplers is what is absent end diastolic flow and the reverse end diastolic flow. So both of the things have increased chances of having stillbirth if not being looked after. So another important topic is the nuchal translucency or the NT measurements in the first trimester screening. So the most important thing that's asked is, how is the NT measured? It's measured in the fetus being in the neutral position, neither to hyperflex, neither to extended, otherwise it's going to be giving a false caliper placement. The caliper placement has to be inner to inner, and the profile should show the nasal tip, the palate, and the diencephalon. So the measurement cutoff we take is 3.5 millimeters. It should be more than 3.5. So how do we work up a patient whom we see NT more than 3.5 millimeters? So the first most thing, immediate diagnostic workup. So genetic counseling and testing, either CVS, amniocentesis, or cell-free DNA. Cell-free DNA is less comprehensive. CVS and amnio are more diagnostic, and need to get a detailed early anatomy scan, especially at a maternal fetal site. What are the specialized imaging and referral for this one? Fetal echo is recommended at 18 to 22 weeks, and tertiary referral at the MFM center. So what are the limitations of a 13-week survey if we see NT more than 3.5 millimeters? Sometimes it's a developmental lag to visualize as 13 weeks. It's too early to see any small cerebellar defects, cortical malformations, or minor cardiac defects or VSD. And sometimes the nuchal increased NT can resolve and it was totally normal, but still there is an increased risk associated. And the last thing, what do we do in the second trimester in such patients? So there is a multi-step reasoning. The most important 3 things to be noted. First is chromosomal, that is CVS and amnio. Rule out any structural defects, that is anatomy scan at 18 to 20 weeks. And to rule out any cardiac defects, you need to do a fetal echo. Another important is the 4-chamber view, which we do at the anatomy scan. So what features should be taken in view in considering a normal 4-chamber view? First, situs and the position. So the heart should occupy 1/3 of the chest, apex tilted to the left, and heart and the stomach on the same side. Cardiac axis should be 45 degrees plus minus 20 degrees to the left. And atrium and the septum primum. So there should be 2 atrium, left atrium, right atrium, pretty much similar in size, and there should be presence of the septum primum, that is the flap of the foramen ovale, in the left atrium. So we should visualize at least 2 pulmonary veins entering in the left atrium. So what should be seen in the ventricles and the interventricular septum and the IVS? So again, right ventricle, left ventricle, pretty much similar in size. The left ventricle is the apex forming ventricle, whereas the right ventricle should have a moderator band, and there should be an intact interventricular septum from the superiormost part to the inferiormost part of the heart. And how do we see the valve, AV valves at the crux? There should be 2 distinct valves, mitral on the left and the tricuspid on the right. Offset of the valves should be there. Insert the tricuspid valve, inserts more apically, and central crux should be intact. And the rhythm and the rate, there should be a regular fetal heart rate rhythm, and normal heart rate is 110 to 160 beats per minute. What abnormalities if seen at the 4th chamber and what it indicates? So the valves inserting at the same level as we studied before, there should be offset of valves. The tricuspid is more lower, so if they insert at the same level, it's more characteristic of the AVSD malformation or trisomy 21. And if we see a pulmonary vein entering the left atrium, it rules out any TAPVC. So these are the all things to be seen at the 4th chamber. And the next is adnexal masses. Lots of questions and very important topic, how to manage an adnexal mass. And the most difficult and most confusing is the mass which is indeterminate or inclusive. Since we know which are mostly benign, we know they need no follow-up or some follow-up annually, and the masses which are malignant, they need further follow-up. The confusion is how to manage the indeterminate or the inconclusive masses. So the first thing is we recognize they are inconclusive or indeterminate. And how do we do that? So if a mass has both B, that is benign, and M, that is malignant features, or none of the 10 features by simple rules, these are the indeterminate masses. What are the standardized safety netting strategies? Expert second opinion. You get another scan by a level 2 ultrasound expert, and MRI. MRI is superior to the ultrasound in identifying the tissue composition and assessing the subtle signs of peritoneal disease. And how do we do the advanced risk stratification and mathematical modeling? By the IOTA, and we need to classify as the ORADS classification, which I'll talk about it in a couple of minutes. And what is the management of a mass that is inconclusive or indeterminate? So surgery versus conservative management. So if a mass is between 5 to 10 centimeters, it is considered as indeterminate, and it depends on the persistence of the mass calculated risk. So if there's a risk of malignancy more than 10%, and if comes in ORADS 4, it needs a gynecological referral. So what is ORADS classification? So ORADS classification is divided into 5 categories: ORADS 1, 2, 3, 4, and 5. ORAD 1 is a normal ovary, needs no follow-up. ORADS 2 is almost certainly benign. ORADS 3 is low risk. Their chances of malignancy 1 to less than 10%, which is managed by a general OBGYN. And ORADS 4 is the indeterminate or the intermediate, which has chances of 10 to less than 50% of malignant potential. So it needs at least consultation or referral to the gynecologic oncologist. ORADS 5 is the high risk, which has more than 50% chances of having a malignant potential, and it mandates referral to the gynecologic oncologist. So what are the key points to be taken care of when we are looking at an adnexal mass? If the size is more than 10 centimeters, likely tumor should be excised. Less than 5 centimeters, these are the functional cysts. They don't need any follow-up, they resolve. And always an MRI is preferred over CT scan. CA125 is less specific in premenopausal women, as it can increase in some conditions like endometriosis. And then we'll talk about what are the simple rules of ovarian lesions, what are the B rules and what are the M rules, and how we call them benign, malignant, or inconclusive. So we have B rules, the benign rules: B1, B2, B3, B4, and B5. So B1 is unilocular cyst. B2 is small solid components, but they're less than 7 millimeters. They're acoustic shadows. Smooth multilocular tumors, they're less than 10 centimeters, and there is no blood flow. What are the M rules? M1, that's an irregular solid tumor. M2 is ascites. M3 is papillary structures present, but they have to be equal to or more than 4. M4 is multilocular solid tumors, that's more than or equal to 10 centimeters. M5 is very strong blood flow. So benign is only B rules and malignant is M rules. Inconclusive are the ones which has both benign and malignant or no rules at all. So for the characterization of an adnexal mass, what are the 2 most important things that has to be considered, since we have 5 B's and 5 M's, and then we don't know what are the 2 most things that distinguish them? Is first is the solid component, and second is what is the nature of a septation. So what is a solid component in an adnexal mass? It is a papillary projections which are specific. These are the solid protrusions from the cyst wall that are equal to or more than 3 millimeters. What is a septation? Septation is across the cyst from one internal surface to another. So there are 2 kinds of septations. There is complete and incomplete. What is called multilocular, that is complete throughout the length. And what is the incomplete septation? It's not covering the entire width. It is a classic sign of hydrosalping. So incomplete septations, hydrosalpings, like beads on string or a waist sign. So this was all about some ultrasound topics and some important features to identify in an adnexal mass and how to manage it. Thank you so much for watching this video. Comment down below if you want me to discuss any other topic which you feel needs more attention, and please don't forget to like and subscribe. See you in my next video. Bye.